Good evening, doctors. Welcome to this webinar on experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993 with got 25 plus years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program on Managing PPH, we have got Honorable Speaker Dr. Abhishek Kothure with us. Welcome, sir. Dr. Abhishek Kothure is MBBS MD with fellowship in minimum access surgery and advanced oncosurgery. Key skills include routine and high risk obstetric care, laparoscopic surgery, gynec oncosurgery, hospital consultations, both indoor and outpatient consultations, fertility consultations, performing obstetric USG and reporting. Work experience includes Matosri Rural Hospital, Nashik, where sir has been consulting gynecologist and laparoscopic surgeon since September 21. Acharya Vinoba Bhave Rural Hospital, Varda, who lecturer from 2020 to 21. Sir has attended several conferences of repute and has published original papers in various journals. Over to you, sir.
Hello, very good evening to everyone. Today we are going to have a quick session just on the case-based studies of high-risk obstetric pregnancies as concerned to the postpartum hemorrhage. So, as we are all know that we have a newer molecule in nowadays concerning the postpartum hemorrhage is carbetocin. Previously, we used to have only minimum tools in our armamentarium, that is oxytocin. Along with that oxytocin, in severe cases, we used to treat with methargine, carboprost, that is prostadine, and a few other drugs like tablets of misoprost and everything else. These all supportive treatments was lacking in one sense that the action of pitocin or oxytocin was very short lasting. Various companies have come up with a newer molecule called as carbetocin. Okay. And now my experience in all these pregnancies regarding the carbetocin I'm sharing today. First of all, we'll quickly go through a demonstration that is postpartum hemorrhage, loss of 500 ml of blood loss in a vaginal delivery or 1000 ml of blood loss in cesarean section. PPH is a common cause of mortality and morbidity in postpartum patients. Next. Postpartum hemorrhage is a very unfortunate yet very common scenario nowadays in all tertiary care hospitals as well as in primary care institutes. In day-to-day or private practice, we are coming across a postpartum hemorrhage cases. The trend is now increasing because of the uh, gestational diabetes mellitus, twins pregnancies, and many other causes. It is the leading cause of maternal mortality in the world as well as the leading cause of maternal mortality in India. The MMR because of MMR in developing countries because of postpartum hemorrhage is 240 per thousand live per 10,000 live births is 16 in developed countries according to a recently published data. The global burden of PPH is around 14 million women suffers of PPH annually, and PPH in India is almost contributing as a 38% of the maternal death. Next. Etiology of postpartum hemorrhage. It is mainly divided into uh, four more common causes. These are four T's of PPH. One is a tone. That is the most common cause of atonic uterus in postpartum hemorrhage. The cause is atonic uterus. Initially, the uterine muscles go in a inertia and they are unable to contract, and this living ligature, which causes the restriction of the postpartum hemorrhage, is failed to take action, and that is the most common cause. Trauma is the second most common cause, even though it is chronologically mentioned as the third one, but it is the second most common cause. When there is cervical laceration or trauma to a cervical structure, it causes a postpartum hemorrhage. Retained products like a tissue or cotyledon of the placenta, this retained product inside the uterus, this causes unable to get a complete tone or complete retraction of the uterus and causes a severe amount of bleeding in patients. And the last cause comes into the postpartum hemorrhage is a thrombin, that is coagulation factor deficiency in a patient can cause thrombin. Now, these thrombin related causes are decreasing day by day as the patients are being more investigated in the good front in the 9 months of period. So, with the thrombin related causes are really going down these days. But what is the most common is atonic PPH, even this today. Next, please. Next. Clinical findings of PPH, abdominal tenderness, circulatory collapse, that patient started presenting in shock-like symptoms and subsequently a shock-like state, increasing abdominal girth, loose uterine contracture, maternal tachycardia, and evident amount of vaginal bleeding. Nowadays, though the book says that the 500 ml of blood loss in normal delivery and 1000 ml of blood loss in cesarean section is by definition a case of postpartum hemorrhage. But even though the blood loss may not be that significant, but if the patient is producing with circulatory symptoms or tachycardia, hypotension, the contour of uterus is not maintained, even in that case, we'll have to take this as a case of PPH when we have to treat it immediately. Next, please. Approach towards the postpartum hemorrhage. First of all, we have to recognize that any cause or any condition in the medical treatment, it starts from the proper diagnosis. As I have recently said, in the cases of postpartum hemorrhage, we have to recognize the cause of postpartum hemorrhage even before it starts producing us evident clinical symptoms. There is evident amount of blood loss, sudden gush of blood followed by clots and abnormal contour of uterus. We should indicate or we should diagnose that this is going to be a postpartum hemorrhage and this is going to produce a significant symptoms. In the clinical picture, we can see abdominal tenderness or loose abdominal, a dough-like feel of the uterus can be noted there, and sudden gush along with the clots and products of conception can be seen in the vaginal canal. Many of the times we can see that the abnormal contour is due to a uterine fibroid. The fibroid is firm in consistency and still we are getting the blood. So the fibroid is playing its role in not getting contraction of the uterus. Immediately we have to send the investigations. One cross-match blood is ready for every normal delivery and every cesarean section in our institute because as we grow up with the situations and we grow up with the protocols, we have made it a protocol that even for a normal delivery, we will make sure that the one blood is cross-matched and ready for every patient who is undergoing a labor. We have to send the investigations, we have to call for the help. Immediately, we have to approach towards the emergency system. The activity in the staff, your staff in the hospital should be well versed with the PPH activity. So in between the scenarios, we are taking the mock drills in a hospital. So everyone is thorough with the protocols. So immediately two wide bore cannulas should be reserved and all the normal drugs or routine protocol should be started. That is a 20 units pitocin, followed by if the patient is normal, we'll see the blood pressure. After that, we'll give an injection methargin and other drug treatment is started. Next, please. Rationale of developing carbetocin in the heat stable formula in this newer generation drug. Oxytocin and ergot alkaloids, we have kept this as the first line mechanism, but we have to maintain them in a refrigerator. And the efficacy of methargin, even though it is proven or time tested, we cannot use methargin in the patients of preeclampsia and other conditions. Heat stable formulation of oxytocin is currently not available with us. So we have to maintain the cold chain in oxytocin. And if someone failed to maintain that cold chain, the action of carbetocin or oxytocin is not maintained. Previous formulations of carbetocin should be stored with 2 degree to 8 degrees Celsius. Even now, few companies have their carbetocin, which is need to be stored in the refrigerator. In a poor resources country or in a developing countries, it is not feasible for everyone to have proper refrigerator and temperature in the cities or some of the towns like in India. Many of the time there are load shedding. In the summer, we cannot able to maintain the temperature between 2 to 4 degrees Celsius or 2 to 8 degrees Celsius. In that situation, there was a need to develop a better molecule which will be heat stable. Next, please. Use of Futrotonic agent and the time of administration. At the time of crowning of the baby's head and at the delivery of anterior shoulder, at the delivery of second stage of the labor and following the placenta. Molecules to be used is first the oxytocin, then carbetocin, ergotamine, and symptometrines. Prophylactic use for the prevention of PPH is also can be used with the heterotonic agents. Active management of the third stage of labor plays the important role of oxytocin and this molecule as a carbetocin. Next, please. As we have already discussed this, the need of heat stable molecule was there in the management of postpartum hemorrhage. As as long as the active management of the third stage of the labor starts, we do a gentle massage of the uterus, and along with that gentle massage of the uterus, we have to have a molecule in a hand that will give you a proper tone of the uterus and which will help us to expel the placenta completely. At the same time, we used to use oxytocin previously. Now we can use with a better molecule as a carbetocin. The main action of carbetocin, next please, the main action of the carbetocin starts on the same receptors of the oxytocin. Next please. And the same receptors of the oxytocin. The synthetic cyclical peptides for the naturally occurring posterior pituitary hormone is oxytocin, a long-acting synthetic analog of the oxytocin with agonistic properties that binds to the same receptors of the oxytocin is a heat-stable carbetocin. Pharmacokinetics is almost the same with increased action that the systemic rhythmic contractions may last up to 60 minutes with oxytocin with carbetocin rather than the action was only up to 30 minutes in oxytocin. The oxytocin we used to administer intravenously as well as intramuscular. This action we can last up to IV administration stays up to 60 minutes and on intramuscular administration it can stay up to 120 minutes. The half-life of the oxytocin is 1 to 6 minutes and half-life of the carbetocin is nearly up to 40 minutes. Some of the advantage of carbetocin over oxytocin is induction of labor. We can use oxytocin, but not the carbetocin. Augmentation of labor, we can use oxytocin and not the carbetocin. Prevention of PPH, we can definitely have a carbetocin only nowadays. We are not using oxytocin for the prevention of and treatment of PPH. Next, please. Carbetocin, clinical evidence-based studies that carbetocin is a not inferior to oxytocin. In fact, it is a superior molecule to the oxytocin. One thing I would like your attention to be put on that the carbetocin is an option to oxytocin, but oxytocin cannot be an option to a carbetocin because once we give a carbetocin to a patient, for 120 minutes at least, the receptors are already binded with the carbetocin and we cannot use oxytocin after the use of the carbetocin. We cannot use oxytocin after the use of carbetocin. Next, please. These are all evidence-based studies that is showing the superiority of carbetocin. The carbetocin was not inferior to oxytocin for the prevention of blood loss of at least 500 ml or use of the additional uterotonic agent is not required when there is action of carbetocin is given already. Next, please. Here is the Cochrane review. that the carbetocin for preventing a postpartum hemorrhage in the Cochrane reviews 11 studies involving 2,635 women. The author says that for the woman who is undergoing a cesarean section, carbetocin resulted statistically a significant reduction in the need of therapeutic uteronics compared to oxytocin. Also, carbetocin is associated with a less blood loss as compared to the symptomatic in prevention of PPH for the women who have vaginal deliveries in associated with a significantly fewer adverse effects. Guidelines and recommendations. And WHO 2018 guidelines that the only following molecules are indicated in the prophylaxis of PPH. Only one of the following, that is oxytocin, carbetocin, misoprostol, ergometrin, oxytocin and ergometrin are the fixed dose combination can be used in the PPH. These are according to a 2018 guidelines. SOGS Canada 2019-2009 guidelines is the carbetocin 100 international units IV bolus can be 100 mg IV bolus can be given for the prevention of PPH and the prophylaxis of the PPH. Even FIGO has given clear guidelines that the carbetocin is recommended in the management of PPH. Many of the reputed associations are giving now their hands off to the carbetocin and not the oxytocin. Next, please.
Sir, coming to your experience, how long you have been using carbetocin?
Since last 2.5 years.
And you generally use what form? I mean, intramuscular, intravenous.
I'm giving a bolus intravenous form. I have not myself not used with a intramuscular form. Personally, what I feel is the action and the efficacy is well tested when we are giving 100 as a bolus in 100 ml saline. The speed of infusion can be controlled. The speed of administration and the effect can be compared and controlled. So we are using it in IV bolus forms.
And you use it in all patients or selective at high risk?
Uh, it depends. If she is a normally primary gravida progressing with a good speed and there are no high risk factors involved, we are still keeping it as a reserve drug. But if the patient is IVF conceived, she is having one or two risk factors, and we are expecting some complications in the delivery, then we are using it as a first line agent. For all cesarean sections, we are giving this drug as a immediate bolus in the drip when the baby is taken out. It
Taken.
helps us the expulsion of placenta and better achieving the uterine tone. For all the normal deliveries with a multi-fetal gestation, if and with a gestational diabetes mellitus on whom polyhydramnios or over distension of uterus is there, in all those cases we are using carbetocin as the first line agent.
And have you experienced any adverse effects?
Not yet.
Thank God. PBH is a condition which is wonderful to discuss, but no one should get it.
Yeah, the all the I have used the monologue once or twice. I have read it. I've gone through the monologue before starting use of this molecule. But all the side effects, they're all theoretical in my
Yeah,
personal
correct,
experience.
correct,
I have
correct.
never seen any of the side effect occurring in a patient because at that way our patients in a private setup our patients are very well tested and they are very well investigated, so there are
Correct.
no surprises in this patient as long as the third stage of labor is concerned.
Absolutely, absolutely. Now coming to a few questions.
Yes, sir.
What is the benefit of using carbetocin as first line drug to prevent PPH?
uh, in my personal experience, the what is the benefit that we don't need a second line of drug first of all. And when we are, it is very easy to administer, even when the nursing staff is new, that we don't have to give them a drip rate or titration rate for this drug when we are using. Simple IV bolus or simple IV drip can be use of this drug, and patients are well compliant with this.
Easy to handle also.
Administration,
Yes.
as we are all know, that the risk of postpartum hemorrhage is higher in first 2 3 hours of the delivery,
Absolutely.
and it is more higher even in the first 30 minutes of the delivery.
Correct, correct,
When we
correct.
are giving a first line drug as a carbetocin, when the actions get fade away in 30 minutes of oxytocin, in that case we are experiencing a second line postpartum hemorrhage in these patients.
Hmm.
But as long as we are using the carbetocin as the first line agent, we are not getting these surprises that patient is lying in the ward and she is in a pool of blood.
Correct. What is a patient profile where the doctors can anticipate a PP? Of course, it can come in any patient, anytime, but generally,
PPH comes as a surprise. It
yes,
is
correct, absolutely.
unavoidable and unpredictable complication in any sort of normal delivery. That's why I've clearly mentioned in my previous slides that all the patients who are going for trial of labor in my hospital, all the patients are the blood is reserved for every patient. Even though she is multi-gestational,
Absolutely.
normal patient with zero risk factor, even that patient, the blood is cross-matched and ready. This is just part of a protocol, but most likely uh, patients with multifetal gestation, because over distension of uterus is one of the major cause for atonic PPH. After that, preeclampsia, especially the patient who has received a Maxilf in last 24 hours, in that patient there is a less tonicity in the uterus and can result into a postpartum hemorrhage. A patient with gestational diabetes mellitus along with a polyhydramnios has similar risk factor of over distension of uterus. And elderly patients, see these patients who are conceived with the assisted reproductive technology and their age is 38, 39, 40, 42. This year we have delivered a patient with 44 year, and along with that she has experienced postpartum hemorrhage just after delivery, managed well with misoprostol tablet correctly and carbetocin given IV bolus. So elderly multigravida, elderly primigravida, multifetal gestations, over distension of uterus, all these are risk factors for PPH.
Anemia could be a major risk factor in our country, no, sir?
Yes, sir. Anemia is a risk factor, but in my practice, I'm not occurring these patients because, as
Okay.
I already told you, in private practice,
Okay.
these patients are well investigated. We have taken care of the anemia in previous settings, so there are hardly any surprises. But
Yeah.
yes, in government medical college, when I was teaching to a students, then at that time, anemia used to be a major cause of postpartum hemorrhage. See, the funda is very clear, which is the nature is taking care of the PPH with living ligature of the musculatures. The living ligature is crisscross muscular layer in which the arteries are running through. As the muscle contracts, these arteries gets collapsed in
Correct.
between, and that causes arrest of the PPH.
Absolutely.
Now, in the cases of anemia, there is hypoxia. The associated muscle gets fatigue very easily,
Oh,
and
yes.
because of the anemia, associated postpartum hemorrhages are more.
Doesn't contract strongly.
Yes, sir.
Any experience, sir, in using carbetocin in retained placenta?
Uh, yes, last year there was a patient of, I've been called for emergency situation. There was a retained placenta which was referred from outside to a medical college. I was teaching to a student and we decided to take that patient in for operation. The plan was very simple. We'll give you anesthesia, uterine relaxants will be given and manual removal of the placenta will be tried. If the
Oh,
placenta is morbidly adherent, plan of obstetric hysterectomy was ready. In this patient, we started while the patient was in a way to shift for the labor room to OT. We started a drip with carbetocin. By the time anesthetist started painting, dripping, cleaning, and anesthesia was administered, the placenta started getting separated
oh,
with the use of
lovely.
sustained contraction of carbetocin.
Lovely.
Yes,
God bless.
and all the subsequent complications were
Yes,
dealt
yes,
with.
yes. In RH negative mothers,
Yes, carbetocin is, as I've already told you, it is just similar to oxytocin. So Rh negativity is not a contraindication or it is not a indication to be withhold this drug in Rh negative mothers. It can be very well given to all Rh negative mothers, provided that we are giving anti-Ds and whose the baby's blood
correct,
group is
correct, correct,
positive.
correct, correct. Doctors generally use, in fact, you answered this. You said that after oxytocin, carbetocin can be used, but after carbetocin, oxytocin cannot be used. You already answered this.
Yes, yes,
I don't
yes.
want to take your time again. In which cases you prefer IV? You have also said this because IV you prefer because of faster onset of action and is more reliable as
I've
compared.
already told you
But
because the
any
action is
experience with IM, sir? Anytime you
no,
have
no,
used
no. I've never used as a IM drug,
uh,
but the scenario is very specific. If we go through a monologue of this drug,
uh,
which is there, as it is a new molecule, generally we are using oxytocin since our ages.
uh,
Now we are that way new with the carbetocin. So if
uh,
you want to predict the route and action of this drug, so what I feel personally is oxytocin, the IV route is much safer. The action is predictable. If patient is experiencing any of the serious side effect of the drug, we can just stop the drip and discontinue it. But once if we
okay,
are given the IM, it will be difficult for us to take it back from the patient.
that is. And how well is it tolerated? Of course, you have said there is no, that you have not experienced any side effects with this.
In my opinion, all the side effects are theoretical for this.
Theoretical, you have already said this. And thank God, because PPH is one thing which one should never get, and add to that side effect of such a drug. If patient is not responding adequately with carbetocin, what in or your order of preference to use other uterotonics?
Yes, it's a very good question, sir, because even we have faced a similar situation quite long back. After a carbetocin, even though there was trickling of the blood, if there is no contraindication to ergot like alkaloids, then methangine should be a next line of drug. Along with
Okay.
that, misoprostol 600 microgram of tablet should be given per rectally because it is going to give you a longer time of action. There is no use of oxytocin. Please make it clear to yourself. There is no
Yes, yes,
use
you
of
have made it, yes.
oxytocin after carbetocin. So carbetocin is out, oxytocin is out of question. Carboprost, okay, similar type of drug, prostaglandin analog, that can be tried in this patient. But again, we have to check for any history of asthma or breathlessness in these patients before administering a carboprost. All these drugs can be tried, but in my practice or in my opinion, the methargine should be a next line of drugs. But with the history, a careful history that patient is not preeclampsia and the BP should be taken into a
Hypertensive,
consideration.
yes, yes, yes. Wonderful, sir. And you have said carbetocin advantage. This advantage of, cold chain not requiring could be a major advantage in the interiors.
Yes, sir, it is a major advantage because in primary health center and even
Yes,
as we all have to accept that the many towns of the India is still having 6 to 8 hours of load shedding
absolute,
in the
absolute.
time of summer. In these days, it is very difficult to maintain the cold chain and the
Correct,
proper effect of
correct, correct,
oxytocin is
correct,
not
correct,
getting or not attained in the patient, and that is one of the cause of PPH in the patients. So the
correct.
heat stable molecule is like magic to them.
Absolutely. It should be, you're using it as a first line, no question of result. To conclude, sir, what is your message to the audience who are attending?
See, guys, we are all friends and we are all learning through each other's mistake. What I have, what is the star of practice of my last 4 or 5 years is if we have low resources set up, if we have any setting that we are afraid to be of, PPH or what will be the monitoring in a post-operative or post-delivery status. In that situation, carbetocin is very safe molecule. Previously, people were used to be the price of carbetocin was used to be a concern, but nowadays companies are coming with so lowest cost
Yes,
that
yes.
400 500 rupees is not a much cost of in when PPH is taken into consideration. So very safe, effective, and smarter ways to tackle a post delivery or postpartum period is the carbetocin, in my opinion.
Thank you, sir. It was wonderful sharing your experience. What happens is that although there is a lot of data, sharing our own doctor's experience is more important than reading those data.
Yes,
It gives the audience a confidence that someone has used this and someone is sharing. Like when you said that you have not experienced any adverse effect, it will give a lot of confidence to people. Your way
yes,
of
sir.
using it gives, and which is why your sharing of your experience has been wonderful and a wonderful experience, practical experience, insights you gave. Thank you so much. I
Thank you,
thank
sir.
all the people who attended this webinar, even in the afternoon time from their busy schedule. Thanks IT team of Hitro and thanks sales team and marketing team for organizing this. Thanks Bhuvan for your IT support. Thank you, sir. Sir, you can log off.
Thank you, sir.
Thank you so much, sir. It was wonderful.
Good night. Good day, sir.